Okay, so it seems like our numbers have stabilized of participants. Thank you for being with us. My name is David Ortiz. I am the faculty fellow for the Center for Latin American and Border Studies class here at New Mexico State University. And I want to welcome all of our panelists and welcome all of you to our panel on COVID-19 in the U.S. Mexico border. Bienvenidos todos a este panel. Mi nombre es David Ortiz. Soy el director del Centro de Estudios Latinoamericanos y para la Frontera de New Mexico State University. Y quiero agradecerles a todos los panelistas por estar aquí con nosotros para este panel de COVID-19 en la frontera México-Estados Unidos. Y quiero agradecerles a todos ustedes que están aquí con nosotros reunidos para hablar de este tema en especial. Quiero anticiparles que para los que hablan inglés, I want to anticipate you that the ones that, for those of you who speak English only, we have a presenter, Dr. Georgina Delgado, whose presentation will be in Spanish, and I will be doing a little translation for you. Para las presentaciones que son en inglés, no vamos a tener traducción en español. Espero que puedan entenderlas. So we will be having a little translation Spanish for our Spanish speaker, Dr. Georgina Delgado, but we will not be translating to Spanish the English speaking presentations, just so that all of you are aware. Without further ado, let me do the presentation for our panelists. Our first panelist will be Travis Leyva. Dr. Travis Leyva serves as the director of the Office of Border Health for the New Mexico Department of Health. Mr. Leyva functions as the primary liaison and point of contact between the New Mexico Department of Health and the public health authorities in the state of Chihuahua and Sonora, Mexico. In addition, Mr. Leyva is the New Mexico Department of Health Secretary's delegate to the United States-Mexico Border Health Commission. As the Health Secretary delegate, Mr. Leyva works closely with Southwest Public Health Division in all 8 of the state's counties on the U.S. Mexico border. He has been published for his work with the 2006 binational border influenza surveillance system between the U.S. and Mexico, and has also been recognized statewide for his creation of the intervention tool iHeal, Integrated Heal Education for Addictive Lifestyles. Thank you for being with us, Mr. Leyva.
Thank you.
Yeah, our next second presenter will be Dr. Georgina Delgado. Dr. Georgina Imelda Delgado Tavares is currently the director of the clinical department at the IMSS, Instituto Mexicano de Seguro Social, and the Unidad Familiar de Medicina Familiar número 46 in Ciudad Juárez, Chihuahua. Dr. Delgado has a medical degree from the Universidad Autónoma de Ciudad Juárez, our sister university here in Chihuahua. She is a certified medical doctor in family medicine from the Instituto Mexicano del Seguro Social. She has a master's degree in administration of healthcare institutions from the Instituto de Estudios Universitarios, and she is a faculty professor in medicine at the Universidad Autónoma de Ciudad Juárez. She's an active member of the Colegio de Médicos Familiares de Ciudad Juárez, AC. Welcome, Dr. Georgina Delgado. Bienvenida, Dr. Georgina Delgado.
Gracias, buenos días.
Lastly, but not least, our last panelist would be Dr. Linda Hill. Thank you, Dr. Hill. Dr. Hill is an MD and MPH and is a professor in the Department of Family Medicine and Public Health at the University of California, San Diego. She is the director of the UCSD SDSU General Preventive Medicine Residency, a senior staff position at San Diego Family Care and FQHC. She is the director of the UCSD Training, Research, and Education for Driving Safety, co-directs with Henrik Christensen the Center for the Human and Urban Mobility, and is the PI of the AAA Foundation for Traffic Safety Long Road Study at the San Diego site. She has directed the Refugee Health Assessment Program since 2008 and is the executive director of the Asylum Seeker Health Program since December 24th, 2018. Dr. Hill, thank you so much for being with us today.
Thanks so much. It's a pleasure to be here.
Okay, so without further ado, I will step off, mute my microphone, and will let Mr. Travis Leyva be the first one to start us with this great set of presentations.
All right, thank you, David. I appreciate it. Let me get my screen going here. Or not. There we go. Can everyone see the presentation, hopefully? Okay. Well, again, thank you very much, David, for the introduction. And I also like to take the opportunity to thank the Center for Latin American and Border Studies for this opportunity, not only for myself, but also for New Mexico. I do want to be able to talk about what we've gone through over the last year and how different it is being a border state with, not only two other U.S. States, but also with a whole other country, being a border state with Chihuahua, Mexico. So also too, I do want to have a disclaimer that, unfortunately I did have a prior personal appointment that I have to get to, but joining me on this presentation is our Border Infectious Disease Surveillance Officer, Ms. Melissa Limon. I will introduce her here in a minute, but I just wanted to go ahead and put that out there for everyone to know. So just a little bit about the Southwest region in New Mexico. It is made up of 8 counties, 4 of them that run right into the border. We border Texas, Arizona, and like I said, Chihuahua, Mexico. But 2 things to note that has been very challenging over the last year is our 2 major port of entries. One in Santa Teresa, which is a very high commercial port of entry for Mexico and the US. And then also Columbus, which too, we do get a lot of commercial passings through that port of entry. And I'll talk a little bit here in a minute about why they're very important to our region. So looking back at COVID in New Mexico, I gotta say, I'm very proud of our state. We've done exceptional in all aspects of public health response to this COVID pandemic. As you can see here on the screen, our state established a dashboard like many others, but public health really took lead in conducting COVID testing throughout the state. One of the operations was to do COVID testing, but also contact tracing and surveillance of everyone who was positive. We tried to put folks out of harm's way of, spreading the COVID infection. So testing was very important. Also, too, in addition to the contact tracing, we had folks that were stepping up and self-reporting, and that too was very important. And I'll talk a little bit more about that as well. Some of the successful interventions that we've had in the last year, and mainly coming out of our Secretary of Health's office, is number one, back in March, of 2020, we were able to close schools. That decision was made to keep the kiddos away and to keep people from going around each other in the community, but also all non-essential businesses were closed. At that time, we were also able to extend testing capabilities. And like I mentioned before, the early tracing of positive cases was crucial in being able to do the surveillance of the COVID infection throughout our state. But of course, too, we were able to enforce some social distancing which are our COVID safe practices. You know, keeping 6 feet away, wearing a mask, making sure to sanitize and disinfect. You know, not just our homes, ourselves, but also our businesses, agencies, and whatnot. Very, very important in being successful and keeping the COVID away. You know, and when we turned the curve there after the summer, we started to see a spike in cases. But also at the time, we also knew that the vaccines were coming. And right now, with our vaccines in New Mexico, we're very proud of what we're able to do. Right now, we have opened up certain phases of folks, community members who can get the vaccine. And right now we're really concentrating on the 75 and over, also 60 and over, and then all educators and school-based employees, because we're wanting to get the kids back in school here this coming next month. So we're really concentrating on this. So again, a lot of work, a lot of planning going into COVID, like everywhere else. But again, too, we want to make sure that everyone has the opportunity. So some of the things that, you know, again, the interventions and what we're doing to make sure that everyone has the opportunity to get the vaccine is we've set some community health workers, health promotion specialists, disease prevention specialists, nurse managers throughout our whole region who are helping everyone who may not be able to register or don't understand the registration process. And that's a huge feat for us because as we know, along the border, we have very rural areas, frontier even, and we want to make sure that the opportunity, again, is for everyone throughout the state. So talking about the port of entry a minute ago, one of the major successful interventions that we incorporated here in New Mexico was the rapid response. It's still in place today. I currently work with representatives from the New Mexico OSHA and Environment Department. And what it is anytime there is 4 or more cases, positive cases of COVID from a business, entity, agency, school, whatever, 4 or more cases in a 2-week period, then we contact the head of that business or agency, whatnot, and what we do is we try to set them up with a close contact surveillance program. We want to see, like, who are these 4 or more cases? Who are they exposed at the workplace? And can we keep them home? You know, it's really important for us because, you know, businesses, we have essential businesses. We have to keep them going no matter what. And we want to work with businesses and agency heads to ensure that their businesses can keep their doors open, but yet we want to keep all their employees and their families safe. We offer testing, contact surveillance, and then also now, you know, we're assisting them with getting registered for vaccine. On the other side, with New Mexico OSHA and Environment, what they were doing was establishing COVID-safe practices. With that, you know, there was a business and surveillance testing plan, and then also too, if they had to close business, they, you know, OSHA went in and advised on cleaning and quarantine for those businesses. Now, the reason I bring this up and why it's so important here in New Mexico, in southern New Mexico rather, is because so many businesses along our border, especially in Doñana, Luna, Hidalgo County, is that we have multiple employees in these businesses here in New Mexico, employees that reside in Juarez, Mexico, or reside in El Paso, Texas, or maybe Thatcher, Arizona, you know, and a lot of times what was happening is the commuters, you know, the folks coming from other states, another country to work. And then they're intermingling with all of our New Mexico residents. So this was very, very important since day one, since April of last year when we initiated this rapid response. to really get a hold of, because we knew that so many commuters a day came through our port of entries. And, and to work, that's what they were doing. They were business types. We had multiple industry agencies and businesses with 400, 500 employees. And out of those 400 and 500 employees, we're talking a quarter or even 2/3 in some businesses of employees that came from other states or another country. So we had to make sure that everyone was staying safe and healthy. And we've been really successful. At this time, we have several agencies that conduct a close contact surveillance and testing every 2 weeks within their organizations. We're able to set up with contractors to do the testing so that, no matter what the exposure is, all the employees are tested on a routine basis to ensure that that business stays open. And like any business, every business is important. We have to make sure that they are safe and being able to operate. So with that, again, so many cases came across the border from Mexico, from El Paso, Texas, or even Arizona, and vice versa, cases that came from New Mexico to folks that reside in those other states. We really heavily relied on our border infectious disease surveillance epidemiologist. And again, she's co-sharing this presentation with me, and I appreciate all the work she's done. She's been instrumental in being a true liaison to for New Mexico to El Paso, Texas, and Chihuahua, Mexico. Introduction, Melissa. She is the Border Infectious Disease Epidemiologist for the Office of Border Health with the New Mexico Department of Health. Her main role is to enhance infectious disease surveillance and identify the binational cases along New Mexico's border with Mexico. Ms. Limon also participates in exchanging epidemiological information with Mexico's colleagues in the state of Chihuahua and Sonora. She received a Bachelor of Science in Microbiology from the University of Texas at El Paso and a Master's of Public Health and Epidemiology from Texas A&M University. And prior to coming to work for New Mexico Department of Health, Ms. Limon worked as a microbiologist for the City of El Paso Department of Public Health Laboratory for the past 8 years. So I'd like to welcome and introduce Ms. Melissa Limon.
Hi, thank you, Travis, for that introduction. Like I said, I'm happy to be here and to share some of our work that we have done. Buenas tardes a todos. I'm going to start off by explaining a little bit about work with binational cases. Binational cases are people that exposed while in Mexico, especially New Mexico residents that have traveled throughout the pandemic to Mexico to visit family, to go to the doctor, to go even grocery shopping. As you know, living in the border, many people travel the border, cross the border every day, even to buy tortillas or to get medicine, to go to the pharmacy. Whatever the reason might be, we track those cases, especially if they contracted COVID-19. We surveillance those cases. Also, those that were exposed while in the U.S., we have had cases. The same thing that happens when New Mexico residents travel to Mexico. We have people traveling from Mexico into New Mexico to visit family. We don't have that much tourism anymore since all the closures because of the pandemic. But we had a lot of people coming into the US, into New Mexico and visiting family, staying here for a while. Unfortunately, many of these cases contracted COVID-19. Some of them were hospitalized here in New Mexico. Also, some came by ambulance from Mexico. Some of these cases were transported to a hospital in El Paso. And then later on, we will find out that they're actually New Mexico residents. And then they were hospitalized in New Mexico or in El Paso. We also had cases brought in by ambulance from Columbus, from the border, and Palomas in Columbus. And they were hospitalized in New Mexico. Unfortunately, some of these binational cases that were visiting from Mexico passed away. We actually had 4 deaths from COVID-19, and we worked with Mexico, notifying them, getting all the information for the case, results. Like Travis was saying, rapid response has been vital for us in the work that we've been doing. For example, we had a major outbreak last year in the meat industry here in the border, and some of those employees lived in Juarez, lived in El Paso. So working with Mexico and El Paso has been very beneficial. Like Travis also was saying, I'm the primary liaison with El Paso Department of Public Health. Since the beginning of the pandemic, they have communicated cases that were New Mexico residents, and we have communicated cases that are El Paso residents. At first, we would communicate by phone, then later on, we would do faxing, but it got overwhelming that we started sending secure emails back and forth with daily cases or weekly cases. And that communication has been very important in our work. Also, many New Mexico residents have been hospitalized in El Paso, and some of them have even passed away. So the city Department of Public Health in El Paso have also reported deaths. And I reported to our central office in Santa Fe. So that communication, I think, has been the most important part of my job during the pandemic. And also, like Travis was saying, rapid response has been very important. And I also have been working with reporting work exposures to El Paso. Like Travis was mentioning, many people cross the border, or they go to New Mexico to work, or New Mexico residents travel to El Paso to work. So of course, they have been exposed at work, and we have been notifying El Paso of these exposures. Most work exposures have been in the medical field, in hospitals, long-term facilities like nursing homes, but also bars, restaurants, industries. So all of this communication back and forth has been very important. We also have communicated close contacts. Since Las Cruces and El Paso and Ciudad Juarez are very interconnected, we might have people that have family members in New Mexico or in El Paso and Juarez. So we also have been doing some contact tracing and also the communications for contact tracing. I have been reporting all those close contacts and cases to Mexico, and in some instances, I have been helping them do some of that contact tracing, and we have been reporting. We've been doing the case investigations for them at instances, and then we send that information to the appropriate health department. And not only to El Paso, but we have been working with the entire state of Texas. Whatever Texas cases that we get in New Mexico, for some reason, they come to get tested in from Lubbock, from into Hobbs and so on. We have been reporting to Texas as well. And I think that's it. Thank you so much. And I can answer some questions later on.
Thank you. Thank you very much. Thank you very much, Travis and Melissa. This is a good time for me to remind all of our participants at home listening to our presentations and our panelists to use the Q&A button at the bottom of your Zoom to actually post your questions. We will let the 3 panelists do their presentations, and at the end we will field some questions. Yvette Navarro, which is CLAB's GA, will be actually answering to you and telling you if your question will be answered live. So please use that Q&A button at the bottom of your Zoom. And with that button, we will know that you're asking questions. If you put it in the chat, we can't do that. So please use that Q&A, and we will get to your questions at the end of the presentation. We already have a couple of questions out there for this set of panelists. So we'll hope to get to them soon. Our second presenter for the day is Doctora Georgina Delgado, and I will be doing the translation for Doctora Georgina because she will be doing her presentation in Spanish. So, Doctora Georgina Delgado, if puede poner ya su presentación en la pantalla, Doctora Georgina, y yo haré la traducción al inglés.
Buenas tardes a todos.
Good afternoon, everyone.
Muy bien. Voy a tratar de presentarles un poquito la perspectiva desde el primer nivel de atención en una clínica de medicina familiar de Ciudad Juárez, Chihuahua.
Dr. Georgina is going to try to give us a perspective from the first point of contact or first level of attention, which means, you know, your first doctor that you go to in a clinic in Ciudad Juárez, Chihuahua.
Un poquito de antecedentes. Iniciamos esta situación de salud en diciembre del 2019, cuando China reporta los primeros casos de neumonía atípica. Posteriormente, la OMS, hacia el 13 de enero del 20, reporta el primer caso fuera de China, que se presenta en Tailandia. Hacia el 30 de enero, la OMS lo declara como una emergencia de salud pública y al 11 de marzo ya nos están hablando de que es una pandemia. Para la región geográfica en la que nos encontramos, el 27 de febrero del 2020, México reporta su primer caso, un viajero procedente de Italia. Para el estado de Chihuahua, el 17 de marzo se presenta el primer caso y fue aquí en Ciudad Juárez. Ahí iniciamos aquí en la región de Juárez. ¿Y por qué la importancia? Nosotros compartimos sociocultural y económicamente con las ciudades de Las Cruces y El Paso, Texas.
So a little bit of background on the issue. First, global background on December of 2019, the first case of atypical pneumonia in Wuhan, China gets recorded. Then on January 13th of 2020, la organización, the OMS, or the World Health Organization, WHO, records the first case outside of China, and that was a case in Thailand. On January the 30th of 2020, the WHO declares a state of public emergency, health public emergency worldwide, and March 11th of 2020, WHO declares this a pandemic. For our particular region, on February 27th, there's the first case of COVID in Mexico from an Italian traveler to Mexico. And then in particularly for this particular region, on the 17th of March of 2020, there's the first case of COVID in Chihuahua, and that actually was recorded in Ciudad Juárez.
La casuística al día de hoy, al día de ayer, 23 de marzo, que es lo que nos atiende, para Juárez reportan 29,538 casos con 2,796 defunciones. El Paso, Texas reportó 128,252 casos y 2,520 defunciones. En la gráfica podemos observar un poquito el comportamiento que ha tenido esto en México, con los picos que presentamos en octubre, los que presentamos ahorita en enero, y ahorita actualmente pareciera que está un poquito estable, sin que esto nos genere una confianza total.
So here's the number of cases as of yesterday. The number of cases in COVID-19 in Mexico are 2,197,772. With 198,239 deaths. In Chihuahua, as you can see, there's 44,996 cases with 5,585 deaths. In Ciudad Juárez specifically, 29,538 cases and 2,796 deaths. In El Paso, Texas, 128,252 cases reported, according to Johns Hopkins University, and 2,520 deaths in the graph. Well, and you can see the cases in the world there, right? 123,800 million and 2,726,000 deaths. What you can see in the graph is the daily cases in Mexico, and you can see a bump in January that Dr. Georgina was talking about, and then some sort of lowering, but now stability in March, which she's cautioning that, you know, although there's stability, this shouldn't cause us to just lower our guard.
En Ciudad Juárez, esta gráfica nos representa un poquito el comportamiento que hemos tenido de marzo del año pasado a marzo de 2021. Como podemos ver, la tendencia continúa a la alza.
So we can see here the confirmed cases in Ciudad Juárez. And what we can see with this is from last March to this March. And of course, the part of the graph that we can see extended here is all the cases this year of daily from March at the end. And what we can see is we still have a tendency to keep getting more confirmed cases. So a tendency going up.
¿De qué manera le hemos dado salida a esto? Primero que nada, es importante que todo el personal que estamos involucrado en la atención conozcamos las generalidades de la enfermedad. Esto con el fin de poder lograr un diagnóstico certero y oportuno para disminuir el riesgo a la población.
So how have we been trying to approach this and try to deal with this pandemic? It is very important that our healthcare workers, especially at the first level of attention, at the first point of contact, know the particularities and the generalities of the disease of COVID-19, and that way they can actually have a clear and early diagnosis so that this disease does not actually keep on going and starts creating more problems in the population at large.
Se comentó ahorita la respuesta oportuna de los diferentes gobiernos a nivel mundial, las intervenciones tempranas por las autoridades de salud, ha permitido que de alguna manera esto pueda manejarse. Y para ello, en el primer nivel de atención se han implementado varias estrategias.
It was commented by our previous panelists that the early response from different countries worldwide has been very important and has made some very important meaningful decisions. And for this, at the first level of attention, right, your family doctor, your first doctor that you see, it becomes really relevant to have this clear diagnosis and early diagnosis, because that's the first point of contact. And in order to do this at that first point of contact, there are several strategies that they have been following in Ciudad Juárez.
¿Qué es lo que estamos haciendo? Estamos trabajando con personas que en los últimos 10 días hayan presentado algún signo como tos, fiebre o disnea y que se acompañe de algún síntoma menor de enfermedad respiratoria.
So what they've been doing is first diagnosing and treating people that have in the last 10 days presented at least one of the following symptoms, which are coughing, fever, dyspnea, or encephalia, which is headache, right? While accompanied by one of another of the following other symptoms that are minor, like myalgias, arthralgias, otophagia, chills, thoracic pain, diarrhea, conjunctivitis, and loss of smell or taste.
Para ello se implementaron algunas estrategias. Antes que esto, se capacitó al 100% del personal de las unidades para que fuéramos capaces de reconocer la sintomatología y poder derivar de una manera adecuada a los pacientes. Se implementaron filtros de acceso a las unidades de medicina familiar, identificando en ellos los síntomas respiratorios, limitando con esto el acceso a las salas de espera, disminuir los aforos en estos espacios y evitar aglomeraciones. Se implementaron también módulos de atención respiratoria. En estos módulos se da atención exclusivamente a la infección respiratoria, tratando de hacer el diagnóstico oportuno y una referencia temprana a aquellos pacientes que tienen datos de deterioro, referirlos oportunamente a los hospitales. Posteriormente, se implementa también la estrategia de pacientes atendidos y que pueden ser tratados de manera ambulatoria, se les da un seguimiento a distancia, que esto lo hace el médico familiar a través del teléfono.
So there have been strategies at 4 different stages and levels. The first thing was to train the personnel, the medical personnel, in diagnosing the disease early enough so that we could then start filtering some of these people to the particular units, right? So with that early identification of respiratory symptoms, and limiting the access to those people in waiting rooms, they could then make sure that they could separate people that were healthy from people that were showing some sort of respiratory symptoms. Then those people got channeled to modules, respiratory modules, right, where they gave priority attention to those patients that had particular respiratory symptoms and that were related to COVID. Then they referred those to those patients that were acting more gravely to the particular hospital. And then the last step of this was to do a follow-up, a distance follow-up of suspicious cases that they could actually evaluate and proactively follow those symptomatic patients to know how their disease was progressing.
Actualmente en los módulos de atención respiratoria realizamos el diagnóstico y el tratamiento oportuno de los pacientes con sospecha de COVID. Para ello tomamos muestras, sea PCR o prueba rápida antigénica, al 100% de aquellos pacientes que presentan sintomatología respiratoria y cumplen con la definición operacional. Además, a aquellos pacientes que sin tener síntomas están en contacto con un paciente positivo, los casos de asociación epidemiológica. Ahorita tenemos el recurso de muestrearlos a todos ellos para así disminuir la propagación.
So what are they doing in this respiratory modules? First, the treatment and early diagnose of any suspicious case with respiratory disease. They're being taking samples with either the quick antigenic test or the PCR test, both, right? So in order to diagnose 100%, this test is applied to 100% of the cases that are in line with that definition that we talked before, but also to 100% of the cases that had epidemiology association. What does mean is they had a contact with someone that was positive, diagnosed positive with COVID. Right now, they have in these modules the resources to do these tests to 100% of these cases.
Este solo nos ejemplifica la manera en que atendemos al paciente. Básicamente es al módulo respiratorio y de acuerdo a la sintomatología o el compromiso del paciente, el médico decide si será tratado de manera ambulatoria o es necesario enviarlo a hospital.
So this is just a graph that shows an example of the treatment diagnose decision process, right? First, the person comes in with some symptoms, and then you can, the person that's treating them in the respiratory module decides if they can be led towards a consultation outside of the COVID-19 system, or do they have to be taken to a hospital and then the rest of the decision-making process.
Los pacientes que se decide que van a ser tratados ambulatoriamente, estos se identificaron y se diagnosticaron de manera temprana. Posteriormente a ellos se les da un seguimiento telefónico tratando de identificar signos o síntomas de deterioro en el estado general y, a pesar de que estén en casa, hacerles referencia a hospital. Con esto estamos tratando de disminuir la mortalidad y de disminuir la transmisibilidad en los núcleos familiares. El paciente es dotado de oxímetros, donde nosotros los estamos monitoreando diariamente y lo acompañamos en la evolución de la enfermedad hasta que es dado de alta o en el caso de que haya requerido ser enviado a hospital.
So how's the follow-up done in terms of cases that might have exposure and cases that might not were ambulatory cases, right? The cases that they referred to not necessarily go to the hospital at the first point of contact. Well, the first thing that gets done, of course, is making sure that those diagnoses are done correctly and refer them to their own homes. But then there's follow-ups on these patients so that they can reduce the mortality. So in case that you were referred ambulatory, you're an ambulatory patients that were referred to your home, there's follow-ups with you to make sure that your particular case doesn't get worse, but also that there's no infections with other family members. All of this is done with two purposes. So there's every 10 days, there's a 10-day follow-up, right, with patients daily, so that you can, doctors can both reduce the number of deaths and also reduce the number of infections towards community and family members.
La situación para nosotros en México con las vacunas. Tenemos un porcentaje de la población vacunada aún muy bajo. Solamente 734,463 personas cuentan con los esquemas completos. Ahorita solo personal de salud y adultos mayores. En algún estado también se vacunó ya a algunos maestros. Sin embargo, continuamos con un porcentaje muy bajo de vacuna aplicada, por lo que ahorita dependemos de los cuidados que cada uno de nosotros sigamos teniendo en los núcleos familiares o en los centros laborales.
What's the situation of the vaccination in Mexico? There's been about 5,781,000 vaccines that have administered. Only 734,463 of those are the complete vaccination, right? So Mexico is in particular right now at a stage in which they're still relying much more because of this low percent of population that has been fully vaccinated, only 0.58%. They're still relying on the staying at home, on the healthy distance, and on wearing masks stage. Until that vaccination, fully vaccinated number of people grows to a larger amount, then they might change, but this is still the stage that Mexico is in.
¿Cuáles siguen siendo las recomendaciones actualmente? Evitar las aglomeraciones, evite salir a lugares públicos si no es por actividades esenciales, evite el contacto con otras personas, sobre todo si sabemos que tienen casos positivos en la familia. El lavado de manos. Actualmente el instituto implementa un programa de lavado de manos y se capacita al 100% del personal tratando de replicarlo esto más allá de los centros laborales. Recomendaciones que a lo largo de toda esta contingencia sanitaria han funcionado, siguen funcionando, es el uso correcto de un cubrebocas, el lavado de manos y limitar nuestra actividad a actividades realmente esenciales. Seguimos dependiendo de esto. Todos como población tenemos el compromiso de atender esto en el lugar de trabajo y en nuestras familias.
So in that sense, then the recommendations are to continue that distancing, social distancing, continue other measures that will hopefully prevent the further infection, like the correct use of surgical masks or any other masks that you might have, to try to stay at home as most possible, especially in urban settings, and limit your activities to essential activities. And of course, not have gatherings of more than 10 people, especially if they're without any correct use of masks and other preventive measures like washing your hands. And they've been training in the workplace to wash hands, and outside of the workplace, hopefully too, in your house, in other environments.
Una última recomendación: ante cualquier duda o síntoma respiratorio, acudan al médico.
Another recommendation is, and this is an important one, is even if you have any doubt, even if you have any symptom that's any respiratory symptom early on, just talk to your doctor, go to your doctor immediately. As Dr. Georgina has been saying, early detection of symptoms is highly important.
Gracias.
Thank you very much. Thank you, Dr. Georgina, for your presentation of the situation in Mexico and Juarez. Our last presenter and our next presenter will be Dr. Linda Hill. So, Dr. Hill, thank you so much for being with us. I will leave it to you.
Thank you so much. Are my slides showing up properly?
Yes, they are.
Thank you very much. So it's been so wonderful to hear from our other presenters, both from the state point of view and from the primary care clinic point of view. And I'm going to talk to you about our experiences as a humanitarian coalition addressing COVID and other humanitarian issues in the region. San Diego and Tijuana are two very intertwined cities. We've heard also about New Mexico and how we're really regional areas. And in San Diego, every day at our San Isidro port of entry, we have something like 120,000 people crossing the border. If you add Otay Mesa and Mexicali, you're at something like 160, 170,000 people crossing back and forth. So from many points of view, including COVID, you can see that we're very connected, that everything we do in one part of our region affects in the other part. In addition to that, in addition to the workers and students and families and tourists, we have a very large number of people, so-called expats, who live in Baja and but may be traveling back to the San Diego region for their healthcare. In addition to that, in our region, there is a very large presence of asylum seekers seeking entrance to the United States. And I wanted to give you some background on this group because it will show you how COVID has really affected our ability to provide humanitarian services. So we know that there are regions in the world that are creating very adverse conditions for their citizens, and really people have no choice but to leave for the sake of their families. The Northern Triangle, Honduras, Guatemala, and El Salvador are just one area, but have been particularly hard hit, and women are particularly targeted. The population is traveling north to the United States, trying to seek a safe haven. In the course of doing so, and leaving their country in the course of doing so, they've encountered many just almost insurmountable barriers, including violence at home and violence en route. That, as I said, that's just one of many areas in the world. There are so many displaced persons. This is just naming a few of the areas. Many of those individuals come to seek asylum in the United States, and in particular, I'm going to speak about the ones that choose to seek asylum in the Baja San Diego area. This is just an aerial view of our port of entry. About 2.5 years ago, the situation of asylum seekers became rather a humanitarian crisis as the numbers increased very largely, and our Department of Homeland Security was releasing people without a safe way for them to get to their sponsors or families. So we collaborated with the humanitarian agencies in our region. I work at UCSD. I recruited physicians and community workers to work with agencies, our Rapid Response Network, Jewish Family Services, Catholic Charities. And we started admitting people to shelters so that we could take care of their health needs, stabilize them, and then unite them with their families by helping them to travel. You can see that over the 15 months before COVID shut the border, that we had very large numbers of people. Here where the numbers go down is the implementation of the so-called Migrant Protection Program, which I fondly refer to as the Migrant Unprotection Program, that then reduced the number of people who were allowed to wait for their court cases in the United States, and were forced to wait for their cases in Mexico, which was a problem because they often didn't have access to housing support and healthcare, and then had trouble getting back across the border. We were particularly concerned before COVID about screening for influenza. We think about those days where scabies and lice and influenza were our biggest concerns, and not wanting people to be infected in the shelter. And we implemented very tight protocols to be able to screen for that, and had 24/7 medical care for our guests, as we call them, in the shelter, and we're able to keep emergency referral rates very low. These are some of the other conditions that we saw, things that one would expect after arduous journeys, difficult living conditions, sometimes some dangerous border crossing, and other conditions, mental health included. Some of the mental health issues were certainly contributed to by the policy of the last regime in the United States. And this is just some pictures. ICE takes away people's shoelaces, so we had to reunite people with shoelaces and let people know where they were, so that our guests would have an idea of where they were going. And here's some pictures from our shelter. We've been moved by the county from shelter to shelter. We're currently in the 7th shelter that we've had, the 3rd since 2018. Now, of course, the last administration created some very adverse conditions for asylum seekers. wait in Mexico, or MPP program is just one of them. The discriminatory application of MPP was another. That just egregious separation of children from their families, detention in adverse conditions, and poorly run asylum hearings. So here's a group waiting for their court case in Mexico, and then the administration denying that they had a policy of separating families when they absolutely did. Pictures that the children drew of their experiences. So this brings us to COVID, and with the border closure due to COVID and the blockage of refugees and asylum seekers, we closed our shelter a year ago. But we continued to have some asylum seekers who were still able to cross. In the meantime, we had to look at what we could do as a region with our partners in Baja. And so we put together a committee that would address what we could do regionally on clinical support, support along the border and in our county to the east, expat support, and the PPE shortage. If you remember back on those days, not that they're completely over, but certainly March, April, May, June, that was a big problem. So the activities that we set up with our partners in Baja included sort of shared experiences. We did a lot of teleconferencing with the universities and the hospitals in Tijuana and Mexicali. We did teleconsulting so that people could present cases and get feedback on them. And I'm going to show you some pictures where we did rounding. What happened in our region is that San Diego was hit first, and Baja followed about a month and a half later. So one of the good things about that is that our ICU doctors and our critical care doctors had some experience with COVID around the time that Tijuana and Mexicali were hit very hard. And one of the decisions that was made in Baja was that any of the doctors over 60 were sent out of the hospital, and many doctors in Baja also contracted COVID. So then once COVID hit, they were in a situation where they had a shortage of physicians and a very, very sick population. So we started at their invitation to round with them, and our ICU doctors went every day for 4 weeks to help the doctors who had been recruited to the ICU when they lost their specialists, to get them the experiences that we had in San Diego, being about a month and a half ahead of time. So we set up a list and sent teams of doctors and nurses to meet with our colleagues at the Tijuana General Hospital, which was set up as the COVID hospital in the Tijuana region. Then Mexicali requested the same service. It's about 2.5 hours from San Diego, as opposed to being 20-30 minutes to Tijuana, and set up a similar system. One of the things that we were able to do is to talk to the nurses in Baja about proning. I mean, it's a new concept. People hadn't been used to proning and putting people face down, but after it was shown to improve outcomes, then we worked with the nurses on that. PPE was another issue. So it turned out that UCSD was fortunate enough to have extra PPE, and we were able to work with the Consulate General in Mexico in San Diego and get PPE delivered to the Baja region, as well as some of the other things that the hospitals were requesting, that where there were shortages of humidifiers for the ventilators, and additional N95s, this kind of thing. So when we look at how did we do in terms of what are the COVID rates in San Diego and Baja, it's really difficult to compare because we were using different systems. So in San Diego, testing became more widely available as time went on, and both symptomatic and asymptomatic people had access to testing, and it then became required for work and school and procedures. What our colleagues told us in Baja was that they were approaching COVID testing in a different way and using a sentinel methodology, sort of more of an epidemiologic approach. But what it means is it makes it very difficult to compare numbers. For that reason, the Consul General, Carlos Gutierrez, approached our group and said, would you help us do a study of COVID-19 in Baja so that we can have an idea of what our rates, what's happened in the past, looking at antibody tests, and what's happening now using PCR. So with our colleagues at UABC, at the Health Authority in Baja, with my colleagues at UCSD who are epidemiologists, we put together a study and raised just enough money to do the testing. Everything else was done pro bono. It was a really incredible effort. And in February of 2021, thanks to the medical students in Baja, we were able to go door to door and collect both antibody testing and PCR testing, as well as administer a questionnaire about knowledge and behaviors around COVID, border crossing, and the effects of COVID on people's lives. Had they lost their jobs? Had they had to leave their homes because of economic reasons, and so on. So I'm sorry to say that I don't have the results of that. We just finished field testing a couple of weeks ago, and all I can tell you at this point is that the rates in Tijuana and Baja, and Mexicali for PCR testing were in the 7% range, and the rates in Ensenada were in the 20s. But those are very crude weights that haven't been weighted, and we expect to have a lot more data around that. And just, to put those numbers in perspective, the rates in Tijuana peaked in early January, early to mid-January. So in February, we expect that the rates were down from their peak. The other thing I think that is reflected in trying to do comparisons, and I can just give you some really crude numbers. So the cases in San Diego County were about 80 per 1,000, but Baja reported cases of about 12 per 1,000. And yet the death rates in Baja per 1,000 were twice that in San Diego. So this is why we think this study is going to be very helpful to look at our region, is because clearly what's happening is that the testing, the differences in the way testing is done and access to testing has greatly influenced our ability to know how many cases there were and make comparisons between each region. And also looking at COVID testing rates positivity in San Diego County, it was 16% in January. So we're in the ballpark. Our region has so many similarities. Currently, we're down to 2%. So as the other speaker said, we have some reason to hope not to let our guard down and to do all of the things that have been talked about in terms of prevention. We also developed some phone apps to help people cope with COVID that we distributed and shared with our Consul General in Tijuana, the U.S. Consul General for administration. And then that brings us to what's going on now with our asylum seekers. So thankfully, we had the inauguration of the Biden administration in January, and with that, changes in immigration policy and the admission of asylum seekers for waiting for their court dates in the United States has started bringing back people who had been deported under the Migrant Protection Program. And also many issues around unaccompanied minors, as I'm sure you've read in the news. So this is groups of people waiting to cross to be able to come into the United States and seek asylum, or as MPP deportees who are hoping to come back into the United States. So with that, we have expanded our humanitarian program, again, working with the agencies, Catholic Charities and Jewish Family Services. Our programs, what we call screen and stabilize, which means that of our guests who are coming into San Diego County, either because of their being let in as former MPP individuals or non-MPP, we're providing screening for COVID-19 symptoms, a self-swab for PCR, and screening for other medical issues. If they need medical care prior to travel, we're providing that. So we take care of chronic diseases, refilling medications, sending people to the hospital if they need it. Some of our guests have late-term pregnancies, so we arrange for prenatal care and then help them in the immediate postpartum period. We're helping the humanitarian agencies with their risk management of exposures, and we're coordinating care across our county and our state and our partners in Baja. We actually have a really wonderful partnership with IOM and UNHCR, who are working in Baja with both Mexican and U.S. humanitarian agencies there, who are pre-screening the MPP population before they cross, screening them for COVID. And as a result, that group has very low rates. We're seeing a lot of people arriving every day. And because they don't travel immediately, the number of people who are under our care has risen drastically. And at any one time, we're caring for 800 to 1,000 people. So we've had to scale up very quickly. I mentioned that thanks to UNHCR and IOM, the positivity rates of our MPP population are less than 2%. But our non-MPP population has not been screened either in Baja nor by CBP. And as a result of that, the positivity rates are 8 to 10%, but have been on a single day as high as 26%. Our county public health has just been wonderfully supportive. We worked out a system where we get the specimens to them. Our guests are either at the port of entry or in hotel rooms where they've been driven by CBP, awaiting our arrival to do COVID testing and provided care there. So going to the hotels and obtaining PCR and then getting them to the county and getting them back in less than 12 hours has just been a remarkable thing. Just a word about the medical conditions that we're seeing. Of course, behavioral health problems because of the stress that people have been under. And then the usual things that people have: chronic disease, pregnancy, and minor illnesses, in addition to COVID. So the challenges for that particular program, amongst all the other challenges that COVID has created for our region, are keeping our staff safe. It takes a lot of staff to take care of 800 to 1,000 people a day, that making sure they're all vaccinated, that they're not letting their guard down, that they're using PPE, that they're following the protocols, that the self-swabbing is done under the protocols we've created that keep my staff very safe. And then the challenge of having to have communication between our screening team based at UCSD, the Public Health Department, and then our colleagues in the Humanitarian Agency, Jewish Family Services, to make sure that our guests, for example, get their medications if they need it. And in fact, if they test positive, our county has been managing the COVID positive individuals from a COVID point of view, deploying public health nurses to take care of them. The volume of arrivals is another challenge, as I mentioned. So I'm going to stop there and give time for questions for the other wonderful speakers as well.
Thank you so much for an excellent presentation, Dr. Hill, and great, amazing work. Okay, so now we have opened our, we have a lot of questions. So there's a lot of interest in this panel, and thank you. I want to thank all of you, all the panelists, for giving us their time today and answering these questions. Doctora Delgado, ya puede abrir su cámara. Melissa, you can open your camera too. We will go ahead with some of the questions that we already have. I'm going to try to get to as many as we possibly can in this 15 minutes that we have left. I mean, you know, the first one, I'll just get out of the way because it is an actual informational question. Eli Valdez asks Melissa and Travis, is there a direct number for senior citizens over 70 to call and register for the vaccine?
Yes, I will add the number in the chat, okay?
Okay. Yvette, if you can then add that number to Ellie's response, I would appreciate it. Okay, so our first couple of questions are for Travis and Andrea. And I'm gonna squish these three questions together. Is there a reason that the numbers, and this is from Andrea Camunes, is there a reason the numbers of vaccinations in each county are not included in the now famous red to green equation that we have in New Mexico? And then the other question that relates to this are how many cases are reported binationally, and how many people do you guys have working on this, since it's an overwhelming situation?
Yes, I'll answer that question. So vaccination is not included in the red to green framework. The red to green framework basically depends on the case rate and the positivity rate. For example, counties that are in red have a positivity rate of greater than 5% and a case rate of 8 or higher per 100,000 people. Vaccination is not included in that framework. And by national cases, we have reported not reported, but we have worked with over 400 cases. Those that are reported are the ones that have a follow-up to do. And binationally, I'm the only one that is working with binational cases. I pull out a report weekly from our investigations, and then I report those out. But our central team in Santa Fe, we have epidemiologists, case investigators, contact tracers that have been working together for all these cases. But binationally, to Texas and El Paso, it's only been me.
Well, thank you, Melissa, for your work. Antonio Garcia says, it'll be important to improve our abilities to innovate and mitigate future outbreaks of this related infectious disease. The border represents an important economic transmission point, so an investment in prevention and protection would yield dividends. I agree. Can there be a follow-up event to discuss ways to use what we have learned and innovate new products to be better prepared? Definitely. I mean, I guess this one is for me about a future event. Definitely, Antonio, we're actually thinking to actually have a symposium on this, from different, the economic impacts, the social impacts, the engineering impact. I mean, there is not only the health impact. So I would, gladly invite our participants here to that symposium, and hopefully we can have a further follow-up discussion on this. any of our panelists wants to talk about Antonio's earlier point of, investment in prevention and protection that would yield dividends. I'll translate this to Spanish. Antonio García, doctora Georgina, pregunta si si es necesario invertir en prevención y protección, porque esto finalmente es para largo. If any of the three of you would like to answer this, please let me know.
Buenas tardes. Definitivamente ahorita, actualmente se cuenta con equipo de protección de manera suficiente. Hace un año efectivamente recibimos, como todos ustedes ahorita escuché, donaciones del empresariado, donaciones de particulares, lo cual se agradeció mucho porque realmente no había donde adquirir mucho equipo. Ahorita en este momento tenemos suficiencia, afortunadamente, pero sí, esto aún nos lleva tiempo y no sabemos el comportamiento que podamos tener. Siempre estamos abiertos igual a recibir donaciones de equipo.
So let me translate that quickly for our English speakers. At least in the situation of Ciudad Juárez, Dr. Georgina says they have enough equipment, they have enough prevention equipment right now and prevention measures right now. In the early stages, they did receive donations and they were very grateful for them. As of this point, they have enough and the necessary for what's happening in the Ciudad Juárez area. Although, of course, this situation evolves and the pandemic is going to evolve, so it will be important to take that into consideration and be open for whatever the future brings.
I'd like to add to that and say that having public health professionals trained at universities on both sides of the border is incredibly important. We were caught in this pandemic with not enough public health professionals, and in fact, in the United States, there's a shortage of public health physicians, for example, and because of some of the political situations in the United States, the lives of those public health physicians were threatened, creating even further shortages. So I think that public health messaging, public health education, it will remain very important.
Great. So I'm going to try, there's so many questions. I'm going to try to get to most of them, but what I'm going to do is I'm going to start stacking them in terms of who they're addressed to. So we did a couple of questions for Melissa and Travis. I'm going to do a couple of questions here for Georgina, and then I will do a couple of questions for Linda. Georgina, Lucila Canseco pregunta, ¿qué medidas, además de las ya expuestas, planean tomar en la frontera de Ciudad Juárez ahora que viene Semana Santa y puede venir un incremento sustancial de la pandemia? Let me translate that to English. What measures are you trying to do besides the ones that you're talking about, because in Ciudad Juárez, because of Holy Week that's coming and there can be an increment in cases? And then the next question, Doctora Georgina, I'll let you answer these two together. La siguiente pregunta, Doctora Georgina, que también le hacen es, what are the guidelines for qualifying for a vaccine in Ciudad Juárez? What are they doing to not only diagnose rapidly, but to fight the prevention and eradication of the pandemic? ¿Cuáles son los seguimientos para calificar para una vacuna en Ciudad Juárez? Y sabe que se está haciendo no nada más para diagnosticar rápidamente, pero para erradicar la pandemia, si es que puede contestar eso.
Ahorita de frente a las vacaciones, al periodo de asueto, las recomendaciones son las mismas. Distanciamiento social, uso de máscaras, evite salir si no son actividades esenciales. Esta no es solo la responsabilidad del sector salud, es la responsabilidad de nosotros como ciudadanos. Si no haya que salir, no salga. Ahorita casi todo lo podemos obtener a través de del teléfono o de mensajerías. Algunas empresas están instalando también túneles sanitizadores y medidas al interior de sus negocios. Por una parte. Por el lado de la vacuna.
Let me try to translate that one first. So about the Holy Week and the break coming, Dr. Georgina Delgado mentions that same types of care, social distancing, mask wearing, trying not to gather unless it's essential. These are the same common responses that we will need to keep on observing in Ciudad Juárez and in other places until the pandemic starts breaking, right? The more vaccination, the more we will get to a point for this. So please keep doing those things. Businesses are also installing sanitizing bridges and other sanitizing measures in their businesses. So those are also happening. And then she will answer the next question.
Sobre la vacuna en Juárez. El programa de vacunación lo está manejando directamente el gobierno federal. Ahorita los grupos a los que se les está aplicando es personal de salud y se está registrando adultos mayores. Aún no se aplica a adultos. Ahorita se está terminando con personal de salud. En el estado, algunos municipios ya están aplicando a los adultos mayores, sobre todo en las zonas serranas o en poblaciones alejadas que tienen mayor dificultad para el acceso a los servicios de salud.
So the Mexican vaccination program is a federal program. And Doctora Delgado also mentions that and it's following right now the elderly, right? 70 plus, 65 plus groups. That's the focus of the vaccination process right now in Mexico. In Ciudad Juárez, there already certain municipalities have started this process and are ongoing with this process. And specifically in places that don't have hospitals and places that have very small clinics or are in the Sierra, in the mountains, in those regions, that's where they're actually concentrating some of their initial efforts. This actually answers another question that we had about rural areas and small areas with no hospitals. So for Paul Doolin, who asked this question, that's already been answered. Gracias, Doctora Delgado.
Okay.
Sorry, okay, so I'll move for some questions for Dr. Hill. Stephanie, first Alondra Dominguez asks, what do you recommend for people from New Mexico to do to help those that are seeking asylum and their current situation? So, from a different state, a different border position, what would your recommendations be, Dr. Hill? And then I'm gonna add this to a second question. Given from Stephanie Arnett, given the relatively slow speed of vaccination in Mexico, how do you expect the situation to continue to develop in the San Diego-Tijuana region? And are there any upcoming events, dates that represent a particular strong risk for increasing infection rates in that region?
Sure. Well, let's talk first about what we can do along the border for the asylum seekers. And I think each state is handling things differently. And some states are very active with their county or their state, or they're accepting federal funds. And some states have chosen not to do that. So I think you have to look at what's happening in your region. We've done some communication along the border for the others who are working with asylum seekers, but it sounds like it really varies from place to place. We've always taken the approach that you protect the individual, you protect the people who are housing with them, and you protect the general public. If you do a good job of screening people, it's good for everybody. It's good for the asylum seeker, it's good for the public. So we've been supported, very lucky to be supported by our county and state to provide that service. And I guess working within your area, working with your humanitarian agencies and seeing what their individual situation is. The slow speed of vaccine. So that's an issue. A long time ago, I was Canadian, and I can say that that's a country also that's been very, very slow to get vaccine, and it's really interfering with the ability to keep the population safe and to kind of move forward. And as a result, they're still implementing the measures that we're talking about that you have to do until you get vaccine widely in the population. San Diego has done a better job. I was looking, San Diego, a county of 3 million, has been able to give 1.3 million vaccines so far. So like there's just these huge differences between countries and between regions. And I think that the problem with vaccine, and again, this is something that we have to come together as a group, whether we're an educational institution or public health department or community agency, is first supply issues and distribution. So just to give you some ideas about what we've been doing in distribution here, we have some mega centers, and then we got a lot of volunteer help. There's two kinds of volunteers. One are the people that register people and support the system, and the other are people who know how to give shots. So just saying, those like doctors like myself who had not in their career been used to giving vaccines, we had to learn how to do that because they just needed bodies to give vaccines. So even doctors can be trained, it's true. And having this kind of community public health clinician, private sector partnership where we all come together and just try to get vaccines in the arms of people. But that can't be done unless you've got supply. And so as each country grapples with how to get supply into the hands of the people who can give the vaccine, then we're still going to kind of be stuck. So every region's doing that, some better, some worse.
Great. We have very little time. There's so many questions still left over. We have very little time. I want to ask a question that might be global. Are there any concerns with mutations? And this is from Crystal Gloss. Are there any concerns with mutations of the virus and what this might cause? So I guess I think that is global for the three of you.
Okay, I can answer some of that. As an epidemiologist, we're closely monitoring new strains of the virus, and we know that we're looking into genotyping more samples. We're also looking into genotyping binational cases, especially. I had a binational case, this case from Juarez. She worked in New Mexico and she got a reinfection. So that's an example of a case that we really want to get genotyped because we really want to see where it's coming from, where these people are going, and especially binational cases. And I'm sure that with asylum seekers, we have discussed that as well in New Mexico, with the possibility of, when we get asylum seekers, of testing them and then genotyping them as well.
Very well said, Melissa. I think that that genotyping will give us really good information. For now, it looks like the vaccines are efficacious against different strains, but as you know from reading the papers, some work better against some strains than others, and for that reason, we're still advising people to be cautious and follow the public health guidelines that we know work so well, and to still not change behaviors because they've been vaccinated.
Doctora Delgado, le traduzco esta, que si hay algunos si tenemos preocupación de las mutaciones y lo que puedan causar.
Sí, creo que como toda la población, estamos ahorita actualmente, pues estamos viendo la nueva mutación que recién nos está llegando y aparentemente ya se reporta un caso por aquí en la región. Entonces, desafortunadamente, pues no tenemos aún vacuna para la de origen y cada vez se está viendo mayores mutaciones que algunas pueden ser más contagiosas, más transmisibles y algunas elevan la mortalidad. Por eso, pero seguimos sin vacuna. Entonces, la responsabilidad es de nosotros como ciudadanos. Eso nos debe quedar bastante claro, que la responsabilidad es de toda la ciudadanía de trabajar desde el punto donde nos encontremos.
So I'll translate that. Yes, there are concerns for some of these variations. There has been a particular, I think, one case reported in the region now, at least, and some of these new variants could be more transmissible. Some of them might cause stronger symptoms that might lead to perhaps a higher increase in death rates. But also, at least in the Ciudad Juárez region, we don't have enough vaccines yet. So without having enough vaccines, the onus falls on the population, right? And I think this exemplifies what Dr. Hill and Ms. Limon just said, which is, therefore, we are all in this together, right? We are all together, should help each other foil that transmission, try to stop the transmission of the infection. And what we need to do is then follow those health guidelines that are very well established and that are working well. Social distancing. Do not go out unless it is essential, especially in periods of high transmission. If you are an essential worker, follow all those guidelines that have been posted. Wash your hands constantly for more than 8 minutes, wear masks, social distance, etc., etc. I want to close up with two things, if you permit me, before I give the last chance for our panelists to say anything. And one of them is, we are going to post this recording to our CLAPS website, so you will be able to hopefully see it afterwards and be able to gather more information afterwards. The last one is just thanking our panelists for a great session. As you can see, there's so much need for this, but there's also so much interest in this type of information. So thank you for the three of you. Gracias, doctora Georgina Delgado, por estar aquí. If you'd like to say one last set of words, we can extend our time a little bit. And we can go in a particular order, I guess. Doctora Georgina, estoy agradeciéndoles su participación y también, si nos quiere dejar con unas últimas palabras, podemos empezar con usted.
Muchas gracias por la invitación. Es importante que como público busquemos la información, busquemos actualizaciones en fuentes confiables. Debemos tratar de consultar siempre una fuente confiable, una fuente reconocida, y definitivamente el trabajo no ha terminado. Nos queda aún mucho tiempo y la responsabilidad es compartida de todos los ciudadanos. Muchas gracias.
Thank you. Dr. Georgina, thanks us for the panel, but also perhaps most importantly say that, it is the responsibility of all of us to make sure that we inform ourselves, and keep current with the information, but perhaps more importantly, that this information that we seek is from recognized sources that are sources that also bring information that has been validated. So please keep that in mind. Also, she says, we have a long road ahead still. The vaccines are here, etc., but we still have a long road ahead. So let's keep in our minds that there's a lot work to do still, and that we, as the public and as communities, as binational communities, need to do our job so that we can hopefully stem the tide of the pandemic. Melissa or Dr. Hill, does any one of you want to have a last word first?
I can go ahead if you like, Melissa. Thanks. I think this pandemic has shown the strengths and weaknesses of our system, political, public health, medical system, you know, even our binational system. And I think as we move forward, starting now, that we need to learn from what happened, keep up our collaboration, always have a humanitarian focus, and make sure that the information that's getting out there is evidence-based and scientific.
Melissa?
Yes, well, thank you first of all for allowing me to speak, given that Travis had to leave. I agree with Dr. Hilla and Dr. Delgado that this has shown so much, and maybe after this is over, we can do sort of like a hot wash to see what worked, what didn't work, and what we can do better in the future, because my work as a binational officer is not finished. I will continue to surveillance infectious diseases, and I'm gonna take a lot of the things that I learned during COVID and practice them in future infectious disease. And most of all, be prepared for the future pandemic, because viruses never stop mutating. And we have to be prepared, and we have to discuss more of what we have learned and share ideas with each other. Thank you.
Doctora Delgado, Dr. Hill, Ms. Limon, I can't thank you enough, not only for being here, but for all the work that you're doing on tracking the disease, on working as a first point of contact, on working with asylum seekers and with others. Your work is commendable. I think I speak for everyone that's here. We are in awe and so grateful for all the work that you're doing in these important times. And thank you for being here with us. Thank you all for being here with us and making this event as successful as this has been. And we will think of a follow-up as we have been told. Thanks, everyone.